Bismillahirrahmanirrahim. Assalamu alaikum. Myself Isha Tariq Bhatti, MPhil Pharmaceutics from Punjab University, and I'm working as a lecturer in Faculty of Pharmacy, Hajveri University. So this is my 7th lecture of Biopharmaceutics and Pharmacokinetics, and the topic of today's discussion is Pharmacokinetics of protein binding. So first of all, we will see what are the learning outcomes of this lecture. So dear students, by the end of this lecture, you will be able to understand what is protein binding, then effect of protein binding on pharmacokinetics. After that, we will study effects of protein binding on apparent volume of distribution, then protein binding and elimination of drug, then drug that is protein bound and actively secreted, then relationship between volume of distribution and drug elimination half-life, then classification of protein bound drugs. So in this, we will start with protein binding. So protein binding is the complexation of the drug to plasma protein is known as protein binding. When a drug binds to plasma protein, it is known as, and it form a complex, it will known as protein binding. Protein binding occurs due to interaction of the drug molecule with the binding sites available on the protein molecule. So a protein molecule, when it interacts with the drug molecule will bind to the binding sites that are available on the protein molecules, and they form a complex in this way. The binding sites are assumed to be preformed, but binding of one drug may also modify the configuration of the protein in such a way that the drug binding influence the nature of binding of further molecules of drug. These binding sites at which the drug molecule bind with the protein are assumed to be preformed, but it is also, it is also proposed that when a protein molecule bind with a drug molecule, the binding of drug molecule with the protein molecule modify the configuration of the structure of the protein in such a way that this drug binding, influence the nature of binding of further drug molecules. Say, for example, when a heme molecule bind to oxygen, hemoglobin bind to oxygen, then this binding influence the, or you can say modify the configuration of the heme group in such a way that it facilitates the binding of further oxygen molecule, so that protein molecule, that is heme, carry the oxygen to the inside the tissue uh, for oxygenation. Then comes effect of protein binding on pharmacokinetics. So in this, we will first consider why we care about volume of distribution. Volume of distribution describes where drug goes. That once the drug enters into the body, or once the drug is administered to the body, where it goes, or where it interact, or to which molecule they interact. Either it bound to fat and bones, either it bound to the protein molecule, or any other action in the body. Then come, it is one of the determinant of how long a drug remain in the body, as there are many determinants that how long the drug will stay in the body. So out of which one determinant is the volume of distribution. This volume of distribution describes that how long a drug molecule will stay into the body. Similarly, protein binding is also a determinant, as it indicates that how long a drug will stay into the body and how it is bounded, and whether it is reversible or irreversible binding. So it depends on that. Then comes a formula that will explain that K, that is elimination rate constant, is equal to clearance over volume of distribution, and T half-life, that is you can say half-life of the drug, is equal to 0.693 divided by K elimination, or elimination rate constant. So rate of distribution will determine how long it takes a drug to reach the desired tissue. Rate of distribution, that after absorption into the body, drug will distribute into the body, or will reach to the target tissue where it perform its action. So how long it takes for the drug to distribute into the body, that from the site of absorption to reach the desired tissue, it will the time duration between that is known as rate of distribution. that at which rate the drug is distributed into the body. Then extent of distribution will determine extensively um, how extensively a drug penetrate different tissues in the body. Then the extent of distribution, that how much drug reaches to tissues, or how much drug will reach to the tissue or available into the tissue, it will determine it will determine, or you can say it will tell us about how extensively the drug will penetrate the tissue, different tissues in the body. Then comes extent of distribution. Extent of distribution depend on volume of distribution in the central compartment, that what is the volume of distribution into the central compartment, or central compartment, which is considered which is also known as the blood compartment. Then volume of distribution in plasma, that is denoted by Vd. And then volume of distribution at steady state, when the equilibrium is established between the volume of distribution in the plasma and the tissue, then it is known as volume of distribution at the steady state. And then protein binding, it also influences the extent of distribution. And then comes effective protein binding on apparent volume of distribution. The extent of drug protein binding in plasma or tissue affect the volume of distribution, and how it affect the volume of distribution. We will discuss this as follow. Distribution of drug is often measured as volume of distribution at steady state, and is the measure of the fluid volume that would be required to contain amount of drug present in the body at the same concentration as it is measured in the plasma. So this is the volume of distribution at steady state. Is the measure of the fluid volume that is required for the amount of drug to be distributed, or you can say that how much drug, or how much amount of drug is present into the body. And it is the same concentration as that concentration that is found in plasma. So next is, it is important to note the measured volumes. It is important to note that the measured volumes are not the actual physical volume, but the apparent volumes, because on dilution of drug in plasma, because they are based on dilution of drug in plasma. So it is important that we should know that all these volumes are assumed volumes. These are not the actual volume, but they are apparent volume. That is, we assume them so that this is the volume of distribution in which the drug is distributed, and these volumes are apparent volume, and because they are based on the dilution of drug in plasma, as the drug is concentrated when it is not distributed into any liquid, and when it is distributed, or you can say dissolved in any liquid, or liquid into the body, or you can say the fluids into the body, it will be diluted. So it is based on the dilution of drug in the plasma. When the drug enter into the plasma, it get diluted. So it is based on that dilution, that how much apparent volume we get. um, then comes drug extensively bound to plasma protein have a low fraction of free drug in the plasma, harder to diffuse, and less extensively distributed to tissues. That is, volume of distribution at steady state will be long plasma half-life. So as the drug is extensively bound to plasma protein, so the free fraction of the drug that is available for metabolism and excretion is a small proportion. So it is harder for it to diffuse, and less extensively distributed to the tissue, as the amount or proportion of the drug that is freely available into the plasma is less, so the distribution into the body is also less. That is low volume of distribution at steady state, and the plasma half-life of the drug, as the drug is present into the plasma, so the plasma half-life of the drug will be increased. Drugs not extensively bound to plasma protein will have greater concentration of free drugs, generally easier diffusion, and greater volume of distribution. As if the drug is not, extensively bound to plasma protein, then the free fraction of the drug that is available into the plasma, it will be higher. So it is generally easier for drug to diffuse, and will have greater volume of distribution. It will be distributed to the more volume, or you can say more tissues, and the volume of distribution in this way will be increased. So next is drug protein binding and elimination of the drug. Effect of bound drug in liver. So what is the effect of protein bound drug in the liver? Drugs that are highly bound to plasma protein have reduced drug clearance. As the drug is bound to plasma protein, so the less drug is available for metabolism or excretion or clearance, then in turn the drug clearance will also be reduced. For a drug that is metabolized by the liver, binding to plasma protein prevent drug entering to hepatocytes, resulting in reduced metabolism by the liver. So as the drug is bind to plasma protein, then when it enter or when it try to enter into the liver cells that are hepatocytes, it will hepatocytes prevents it entry into the cells. That is because of larger molecule, that is the protein molecule is larger molecule. When it bind to the drug, it is even bigger, so it is very difficult for this bigger molecule to get inside the hepatocyte and resulting in reduced metabolism by the liver. So in addition, molecular bound drugs may not be available as substrate for liver enzymes, further reducing the rate of metabolism. Um, in addition to that, drugs that are molecular bound drugs, they are also not available for as a substrate for liver enzymes, and in turn, it will further reduce the rate of metabolism. Then comes effective protein bound drug in kidney. So the protein bound drugs act as a larger molecule that cannot diffuse easily through the capillary membrane in the glomeruli. So in glomerular capsule, or you can say that glomeruli is the network of capillaries that will in which will help in the filtration of drug, and that once the drug enters into the enter through these capillary, then it goes into the nephron, and then it will perform its action. Um, so once the drug is bound to plasma protein, it is the larger molecule. And for this large molecule, it is very difficult to diffuse it through the capillary membrane in the glomeruli. So these drugs cannot be excreted by this route of elimination, that is the renal route of excretion. The protein bound drugs such as cephalosporin will be excreted by, which is excreted by renal route, generally increase the excretion process as percent of drug bound to plasma protein increases. This is the type of drug this is the type of the drug or the group of the drug that is actively secreted even if it is protein bound. Why this is so? Because for these drugs, renal route is not only the route of excretion from the body. These drugs may also excrete through biliary route. So if the drugs are bound to plasma protein, they are bigger molecule, they cannot diffuse through the glomerular capillaries found in the glomeruli. So what happened, these drugs get excreted through the bile, and in the end they are excreted out of the body by fecal material. So that is why cephalosporins get excreted extensively even if they are bound to plasma proteins. So the example of this, you can consider that the effect of serum protein binding on renal clearance and elimination half-life on various tetracycline, as it is shown. Drug name doxycycline, it is 93% bound to plasma protein, and elimination half-life is 15.1 hours. As it is extensively bound to plasma protein, so its elimination half-life is also increased. As in case of oxytetracycline, it is 35.4% bound to plasma protein, and its elimination half-life is 9.2. It is less than this because it is less bound to plasma protein as compared to doxycycline. So drug that is protein bound and actively secreted. So here it is, drugs that is extensively plasma protein bound and excreted by the kidney, such as penicillin, have shorter elimination half-life because active secretion takes preference in removing and stripping the drug from the protein as the blood flow through the kidney. So what happened in case of drugs that are extensively bound to plasma protein and excreted by the kidney. So what happened in case of penicillin? They have shorter elimination half-life because then it bound to plasma protein. And the preference of route of elimination, or you can say the preference in excretion, is that the drug is stripped from the protein. And stripping, that is, the small molecule of the drug get detached from the protein and it get excreted um, when the blood flow through the kidney. And this molecule, you can say that the drug and protein binding, it get detached from it. A piece of drug is detached from that, and it goes into the and it get excreted through the kidney. So in this way, the accumulation of this drug, or you can say the build of this drug into the body, does not take place. Then, in this example, in this we can consider the example of cephalosporin. As cephalosporins are excreted both by renal and biliary excretion, and penicillin, these two are the examples of drugs that are protein bound and actively secreted. So the half-life of the drug is significant, that is significantly excreted in bile, um, significantly excreted in bile, and does not correlate and do not correlate well with the extent of plasma protein binding. So if we consider the half-life of the drug that is excreted in the bile, it will not correlate to the the extent, that is how much it is bound to plasma protein. So it is not related to that thing. Then comes relationship between volume of distribution and drug elimination half-life. So drug elimination is mainly governed by renal and other metabolic processes in the body. Clearance is related to apparent volume of distribution and elimination half-life, elimination rate constant K, as it is shown below. So as I have told you that clearance is equal to K into volume of distribution. K is elimination rate constant, and VD is the volume of distribution, and CL is the clearance. So half-life is equal to 0.693 volume of distribution divided by clearance. So what we derive from this, expression, that T half-life is prolonged, that is T half, that is half-life of drug is equal to will be prolonged if the clearance is constant. If the clearance is constant, then half-life will be prolonged and the volume of distribution will also be increased, as T half-life and volume of distribution are directly proportional. So if the T half-life elimination, you can say that half-life is increased, then it will directly proportional to, as it is directly proportional to volume of distribution, so the volume of distribution will also be increased. And now we consider that drug with a larger volume of distribution and longer elimination half-life. Normally, small clearance lead to longer half-life, but in this case, drugs having larger clearance and elimination half-life is longer because of large volume of distribution. So what happened in this case? We consider the example of macrolide antibiotic, erythromycin, given once daily, having given in once daily dosing, and it have volume of distribution 800 liters, and elimination half-life is 44 hours, and the clearance rate is 226 to 1040 ml per minute. So this is regarding the drugs that have longer half-life and have large volume of distribution, and drug with small distribution volume of distribution and long elimination half-life. So what happened in this case? If we consider the example of tinoxicam, which is an NSAID, it have the following characteristic, that it is 99% bound in human plasma protein. It has low lipophilicity. It is highly ionized and distributed in blood, so poorly distributed to the body tissues, and have less volume of distribution, that is 9.6 liter. So lower body clearance, that is 0.106 liter per hour. So longer elimination half-life, that is 67 hours, due to extensive drug protein um, binding. So next is classification of protein bound drug. On the basis of elimination, the protein bound drugs have been classified as restrictively eliminating drugs and non-restrictively eliminating drugs. So First of all, we considered restrictive elimination or drugs that are eliminated restrictively. The drugs that the unbound fraction of which is available for metabolism are described as restrictive eliminating drugs because of protein binding. Only the unbound fraction is available for elimination. Such drugs have extensive plasma protein binding with very small plasma clearance, as they are extensively bound to plasma protein. So, a very small proportion of it is available for clearance. The hepatic extraction ratio of such drugs are smaller than their unbound fraction due to strong protein binding, as it is, the drug is extensively bound to plasma protein. Very less fraction is available for elimination, or for so the drug that is extracted from the liver, or you can say that from that is removed from the liver, will be even smaller than the unbound fraction. So the example of these drugs that are restrictively eliminated are phenylbutazone, oxycam, piroxicam, isoxicam, and tinoxicam. So then non-restrictive elimination. Some drugs may be eliminated even when they are protein bound, and drugs in this category are described as non-restrictively eliminating drugs. So the example of such drugs is non-steroidal anti-inflammatory drugs, propanolol, uh, diazepam. So these are the example of the drug that are eliminated, that are actively excreted even if they are protein bound. So the summary of this lecture is that we have studied protein binding, then effect of protein binding on pharmacokinetic, effect of protein binding on apparent volume of distribution, then protein binding and elimination of the drug, then drug that is protein bound and actively secreted. Examples are penicillin and cephalosporin. A relationship between volume of distribution and drug elimination half-life. Then classification of the protein bound drug, that is restrictively eliminating drug and non-restrictively eliminating drugs. So thank you so much for listening. If you have any question pertaining to this lecture, you can ask me on Google Classroom discussion board, and the class code for Google Classroom is mentioned as it is mentioned here. So thank you so much.